Goals of care conversations are those ongoing dialogues between a member of the care team or multiple members and the patient or their support people. And they really get to the heart of what matters most to the patient in the context of establishing a shared understanding of what's happening with their health. These conversations ultimately guide how we provide care at every stage of someone's health journey, at every stage of the hospital visit, and can even inform decisions beyond this acute care admission, such as discharge destinations or the degree of intervention, and the supports we put in place. Quite often, the term goals of care gets brought up synonymously with some other types of conversations. And while it can include these things, it's not limited to conversations that we have in formal family meetings. It's not limited to conversations around disclosing difficult news, prognostic updates. Neither is it limited to discussions only about end-of-life planning or death and dying. And these conversations have a lot of value, even if they don't lead to an immediate medical decision. So instead, we want to kind of broaden our view of goals of care conversations to think about them as a normal part of how we provide care. I've even heard it called the sixth vital sign. These conversations really are foundational. They lay the groundwork for making holistic medical recommendations and doing interprofessional care planning. They also provide a compass. They provide us direction that helps all of us to be paddling in the same direction in partnership with patients and families. There are often several conversations, sometimes bite-sized conversations, sometimes multiple meetings. And all of them address the holistic nature of the healthcare needs of the patient and the people around them. Gary pulled this beautiful slide together talking about the importance of conversations around goals of care. So it's estimated that about 70% of patients would actually prefer a comfort-focused level of care as they're approaching end of life. However, very few, especially even in Canada, have actually documented those care preferences. And in the absence of having proactive goals of care conversations, we see an increase in ICU admissions. We see disparities in levels of intervention, like a most order. Sometimes we see unnecessary hospitalizations or transfers to acute care from community. And when we do take that team-based approach to goals of care conversations, we see significantly increased rates of family satisfaction with care. And I would add increased increased satisfaction with patient experience. So again, to make sure that we're talking about apples and apples, what do we mean with interprofessional approach? Because I think it's a term that's thrown around synonymously with multidisciplinary and interdisciplinary, but it's actually not the same thing. So in an interprofessional approach, we're really looking at one another on the care team as having overlapping expertise and an appreciation for the fact that we all have unique contributions to make to this partnership with the intention of all achieving a common goal. So again, it's recognizing that within our scope of practice, for multiple different professions, we have a unique perspective and a unique area of expertise. And so it allows us to better support the diverse needs that patients and families have, especially beyond the physical. And how does this differ from multidisciplinary or interdisciplinary? It's all about relying on one another by having mutual trust in each other's abilities and in our roles. It takes a lot more collaboration to have an interprofessional approach. And sometimes there is a shared role that's common to more than one profession. So recognition and value in that shared area of expertise. Whereas when you're taking a multidisciplinary or an interdisciplinary approach team members might be working in parallel on the same patient, and we're all trying to perhaps improve the patient's overall health, but there are much stricter disciplinary boundaries, and we may be working on different goals without necessarily all paddling towards a common goal, and that common goal might not even be clear. So we all have a role to play: OT, PT, social work, SLP, physicians, nurses, all of us. And I think this brings us back to an important point about these are not always formal conversations. There are many conversations that happen organically as a natural part of our interactions with patients and families. And just like I wouldn't want my husband to pick up my cell phone and scroll through my contacts and pick who I would want to share some personal information with, patients and families choose who they feel safe talking to, the degree to which they're willing to share information that they might otherwise hold close to their chest. And that person also may happen to be in the right place at the right time. And so that could be the physiotherapist, speech language pathologist, the dietitian, the care aide. Gary's got a great story about a housekeeper. And so we all need tools in our toolbox to skillfully handle the conversations that emerge and to listen for trigger statements or natural windows of opportunity that arise and allow us to elicit goals of care information from patients and families and meet them where they're at. Using those different interprofessional perspectives, it allows us to get to the heart of patients' questions and their worries beyond the physical. So people have spiritual concerns, financial, psychosocial, vocational, etc., concerns that make them who they are and that speak to the variety of impacts that having a health condition has on one's day-to-day life. And so if we all lean into our areas of expertise and practice within our full scope of practice and trust each other to do so, then we can actually pull together a much bigger puzzle of multiple pieces that start to create an image of who this person is and how we can best support them moving forward. And this article by Cruiser and Al is fantastic. It talks about how we do, the nature of our interactions are different depending on our discipline. We have unique points of access. Sometimes these conversations as an RN come up in the middle of wound care or when I'm waiting at the bedside to wait with the patient while a blood product is running through in those first 10-15 minutes. Physios have opportunities sometimes in the middle of a rehab session. And so those interactions differ. But if we see each other as being assets to the bigger picture, then we can build this really rich, collective, deep well of knowledge about who the patient is and what they're hoping for. And when we fail to do so, then this knowledge is often dispersed amongst the care team. Some people are even reluctant to chart the things that they know or to share it between professions. And so it leaves us with a missed opportunity to really actualize our full potential as a care team. So on our goals of care support team, how do we promote this sort of team approach? Our team has existed now for about 8 years with Vancouver Coastal Health. There's 5 of us on the team, many of which are on this call. And it's all about making sure that we are respecting the scope of practice of each of our professions. And so we do tailor our education when we are providing discipline-specific education on goals of care to case study examples, strategies, workflows that make sense for that specific discipline. So if we're talking about wish, worry, wonder statements, for example, with social workers or OTs, we're actually adjusting our language to meet the discipline-specific scope of practice. And it's great to collaborate with the practice leads that are available for the various professions as well and lean on them when in doubt with scope of practice. We see goals of care education as also an opportunity to continue to socialize that shared responsibility, recognizing that everybody has a part to play in collecting and sharing goals of care information to make sure everyone's holistic needs are met as a patient. Before having team-led goals of care conversations, so if you're heading into a family meeting or a bedside conversation with more than one discipline, encouraging that moment of gathering in advance to coordinate an approach. Identify what you're hoping to achieve as part of this discussion, who's going to lead the conversation, and what do the various members of the team wish to express or share, or ideas around what's worth exploring and leaning into. It's also important that in creating an interprofessional approach, we constantly remind ourselves to treat one another as if we're all intelligent, capable, and caring members of the care team. We're all there to do our best. It doesn't mean we're not going to have slip-ups. We're all human, but we're all there seeking to improve and provide the best possible care. And then one of the last, but I would say one of the most important things is fostering that culture of psychological safety within our care teams and amongst the various professions. So if we're hoping to take that inclusive approach and to be an approachable individual on our care team, where we do receive the maximum amount of information that is gathered from point of care, then we need to continue to be mindful of how we respond when people bring goals of care information forward, because how that person feels within that interaction can encourage or discourage them from bringing information forward in the future. So another way that we socialize the shared or interprofessional responsibility as part of the VCH Goals of Care support team is I'm really excited to share that we're actually a team that's made up of multiple professions. 3 of us on the team are nurses. We also have a social work lead and an OT lead. And I think that really adds to the richness of the education that we provide and the lenses that we bring to adapt and pivot when we need to in our training. Our team web page, both the external web and our intranet page, really speak to the value of an interprofessional approach. And we have monthly interprofessional workshops where we actually get to see each other in action, having these conversations through simulation, and learning from each other. I think part of making goals of care a more normal part of practice is also building the infrastructure. So making sure that you have things like policies and practice guidelines that support that interprofessional approach to practice. And our team hosts quarterly webinars and sends out newsletters. The recordings for the webinars are on the Learning Hub. I think we have 12 open to all health authorities on various goals of care related topics. And at the bedside or in acute care teams, I also think it's important to consider including nursing and allied health in family meetings, being mindful of obviously what the topic is being discussed and what people's availability is. And before I pass it off to Emily, wanted to point out some of the interprofessional conversation resources that we use in our education. There are certainly plenty more where these came from, but there are various conversation guides, the Serious Illness Conversation Guide, the adapted version from FNHA and BC Centre for Palliative Care. There are several other adapted conversation guides on our webpage as well. And I feel like we're just constantly finding more that have increased value as well. We have a worksheet for patients and families that's available in 5 or 6 other languages besides English. That's also on a publicly accessible website. That's the vch.eduhealth.ca. And it allows essentially the questions from the Serious Illness Conversation Guide to be reflected on by patients and families and considered before heading into a family meeting, or to discuss it amongst themselves and to write in their answers. And the last 2 resources, the hyperlinks are included, but it provides additional guidance for perhaps more challenging goals of care conversations. That's the reference guide. And then Ariadne Labs has a social work specific guide on within their scope what that looks like to have a serious illness conversation. And last but not least is, when do we have these conversations? I've already mentioned that these are a series of conversations. It's not a one and done. It's not have the conversation for the first time when all of the treatment options are not working. It's start these conversations, however small they might be, on admission, and make them a normal, benign part of how we provide care. Revisit these conversations if there's an important development, a new diagnosis, significant complication to the treatment that we're providing. When patients have been in hospital for a significant period of time, be it weeks, months, or longer, people's goals and needs and worries change over time as they experience different treatments, as their illnesses change, and there's ebbs and flows in their health. And so coming back to the goals of care is really important. And last but not least, before discharge, especially if you've got someone that you're expecting some instability in their health, they're vulnerable or they may be frail, reflect alongside the patient or their decision makers on what they would want or maybe not want the next time. Hindsight's 2020, and so having just gone through a number of different interventions, it's an opportune time to have these conversations. I will mute myself and hand it over to Emily.
Thanks, Dara. So as a allied health worker in acute care, I found that looking for opportunities to have goals of care conversations with my patients is just part of my normal everyday routine has been really helpful in me understanding how to best support my patients. And I routinely use strategies from the serious illness conversation guide that Dara mentioned when having these goals of care conversations. So an example of one of my favorite strategies from that guide that Dara alluded to already is the wish, worry, wonder strategy. I like this because it allows us to show that we've been listening to what patients and families are hoping for, that we're on their side, that we're wishing for the same things that they are. But at the same time, it's an empathetic way that I'm able to express my realistic concerns that we may need to prepare for a possibility where things don't turn out exactly as they might hope. So for example, in my work as a speech therapist, if I'm working with someone who's expressing a wish to communicate verbally, but for whatever reason is not able to do so effectively, I might say something like, I want to talk to you about your communication. I know you want to focus on learning how to talk again. I wish that you could express yourself through words as well. But I worry that other people will have trouble understanding what you want and what you need if we rely only on verbal communication or communication through words. I wonder if there's another way of communicating that might help you to express your needs and wishes to others. Is that something that you might like to learn more about? Another strategy that I love using routinely is assessing patients and families' understanding of their health or different aspects of their health. This allows us to appreciate if patients and families have understood the education that we've provided as well, so that we can provide further education as needed to support their ability to reflect on what their goals are and to make important decisions. I also really like it because when patients are telling me what they understand, I can use their own words and their own ways of describing things to meet them where they're at and provide further education as needed if there's any information that I think might be important for them to have. That can be a starting point for me to provide that. An example of this is perhaps I have a patient with difficulty swallowing. After providing education about the potential risks versus the potential benefits of fluid thickening, I might ask the patient or family to give me some examples of the different risks and benefits that they've learned about, so that if there's anything that might be missing, I can help to fill that in. And as far as the patient and family impacts of allied health participating in these goals of care conversations, I think there are many, but I'll touch on just a few. One thing that I notice frequently is that patients and families who seem to have had prior goals of care conversations before being admitted to acute care and working with me, they seem to experience less anguish when making difficult decisions, and sometimes seem to agonize less over decisions. So for example, I've had many patients, families tell me something to the effect of, you know, the dietitian at my mom's long-term care center told us that one day she might have trouble swallowing because of her condition. Back when my mom was able to communicate her wishes on her own, we talked about this, and we talked about whether she might want a feeding tube if she was unable to eat on her own. Whereas I've also had families where, you know, it seems like perhaps they're learning some information about swallowing and what to expect with their loved one's condition for the first time during a medical crisis, when the patient themselves is not able to express their own wishes. These families seem to struggle a little bit more because obviously, you know, they're under emotional stress and time pressure, and that's just not a great context for you know, making decisions and reflecting on your goals and values. Another thing that I notice is that having goals of care conversations early and often can help us to guide patients and families in decision-making processes in a way that aligns with their specific goals and values. I think most of us as clinicians have experienced scenarios where we might be offering different management options to a patient and their family, and they might say something like, you're the professional, we'll do what you think is best. I notice that when that comes up, if I've already sprinkled in some goals of care sort of topics into previous conversations with patients and families, I'm better able to center the focus of the conversation back to their goals and values, even when their initial response might be to defer to me. So as an example, going back to discussing the risks and benefits of fluid thickening, if we are having a family who is having a difficult time deciding on what to do with that, and you know, wanted to defer to me because I'm the professional, I might say something to the effect of, yes, I know a lot about swallowing, but I don't know as much about your aunt and what's important to her. My job is to provide you with the relevant education to help you to make a choice that works best for your aunt. I heard you say that you're quite worried about your aunt getting dehydrated and that she's been complaining that she really doesn't like the thick fluids from the hospital kitchen. Dehydration is a potential complication of fluid thickening. Perhaps then we could talk about some other ways we can help your aunt to avoid developing an aspiration pneumonia whilst developing a risk of aspiration pneumonia while also honoring her preference for thin fluids that she's been showing us. As far as how my conversations with patients about goals of care support the larger healthcare team, echoing what Dara was said about, you know, us all having different areas of expertise. We all have overlapping but unique wealths of knowledge to share with patients and families that will help them to reflect on their goals. You know, as an example, if I'm providing education about swallow function to a family, oftentimes questions about nutrition and tube feeding come up. And, you know, it's really important that I lean on the expertise of my RD colleagues to help fill in the information that patients and families are wondering about that I myself cannot provide. Another way that allied health participating in goals of care conversations is that, you know, collectively we spend a lot of time with patients. The MRP, the most responsible physician, is just one person. But if you consider, you know, what a patient's day looks like, maybe in the morning they go for a walk with the physio. At lunchtime, the RD checks in to see how they're eating. Maybe spiritual care stops by for a visit in the afternoon. These are all opportunities to discuss goals of care. And if we, you know, look for these opportunities, you know, piece by piece, little by little, as a team, we'll learn more about the patient and what they value and what's important to them. I think also our participation as allied health members can possibly promote better continuity of care. Physicians caring for patients in hospital often hand over to new physicians after a set period of time. but a member of the allied health team might follow a patient for longer. So if a patient and family builds a good rapport with a certain member of the allied health team, they might feel more comfortable having goals of care sort of discussions with that team member. And then that team member can be an advocate for that patient to continue bringing the team's focus back to what the patient has expressed that their wishes and their values are. Many hands make light work. If we're all making a point of documenting these goals of care conversations somewhere centralized, it can help during the admission that the patient is having currently, but also can go beyond that admission, so that if the patient is received by other healthcare providers, they now have a starting place to work with that will help them to understand what the patient's wishes and values are. And next slide, please, Dara. So to illustrate how allied health can work together with the rest of the team to support goals of care conversations, to promote the best possible outcomes for patients, I'll discuss an example of a case where I worked as part of the team caring for a frail elderly gentleman when he was admitted to hospital for several weeks. This elderly gentleman had a history of advanced dementia and a long-standing prior history of swallow dysfunction, which was managed by diet modification. So at his long-term care home, he was eating pureed food and thick fluids. He was admitted with the flu. It seemed like his swallow function had worsened at the time of this admission. During a video fluoroscopic swallowing test, he aspirated on all consistencies of food and fluids. And he also wasn't eating very much. During the hospital stay, he developed recurrent aspiration pneumonias and delirium. An NG tube was placed to see if, given some time to recover from the flu, perhaps some of his swallow function might recover. However, after weeks of tube feeding and some complications related to the tube feeding, the swallow function did not seem to be improving. And I was starting to worry that because of the progressive nature of his dementia, the swallow function could possibly be reaching a new baseline. The patient himself was unable to express his own wishes clearly in words, but I noticed that when I visit with him, he was showing an interest in food, often reaching out for it when I offered it during a swallowing assessment, or doing gestures to show me that he appreciated that I was bringing him food and fluids. Family had a decision to make about feeding despite suspected aspiration risk versus going with G-tube feeding or going with some combination of the two. So different team members during this patient's admission had many goals of care conversations with the patient over the course of the whole admission, and we were really good about sharing what we learned with the rest of the team. So I'll give some examples of that. So the social worker noted that even though the family's English was quite good, they did benefit from interpretation being offered, which then facilitated everybody else's conversations with the family and helped to make sure that they were understanding the information that was provided and were able to effectively communicate their wishes and values. Early on in the admission, when I was collecting a history during the swallow assessment, I asked the son of the patient what he understood about his dad's swallowing. He told me his food has been going down the wrong way. He aspirated. That's why he has pneumonia. Learning about the son's concerns about aspiration became relevant later in the admission when discussing tube feeding. The RD and the geriatrician knew that it was important to inform the son that tube feeding does not necessarily remove the risk of aspiration. During the same conversation I had during the first swallowing assessment, the son expressed his wish that he hoped that the dad could go back to feeding himself by mouth again, as he had done at the long-term care center prior to his admission. The son mentioned to one of us that he was worried that his dad would starve without tube feeding, as he wasn't eating very much even when food and fluids were offered orally. Because somebody brought this forth to the team, the nurse specialist was able to provide education about the progression of dementia and how this affects the body's need for nutrition and hydration and feelings of hunger and thirst. I was able to share with the son that during my many visits, even though he couldn't tell me in words when he felt that he had had enough to eat or drink, that he was actually quite good at showing me. So he would hand me the food when he was done eating and, do a gesture to show me that he had had enough. This allowed the son and the family to consider that although the patient was unlikely to eat very much orally, he may not be feeling like he's starving, which was a big concern for the family. And I think that provided them a lot of comfort. Another thing that was really positive in this case is that, I had clearly documented and many others had clearly documented over the course of the intake, over the course of the admission, how much the patient was showing us his desire to eat orally. And how the son was also expressing that same wish. So when we were having important conversations about decisions, we knew that it was important to center the wish of the patient to eat orally and the wish that the family shared to eat orally, to make sure that we gave options that aligned best with this goal. So for example, the MRP discussed possible medical implications of feeding orally versus tube feeding. I, as an SLP, discussed how to mitigate aspiration risk if we were to feed orally. And the nurse specialist spoke about the potential quality of life benefits that could be associated with oral feeding. Someone during the admission learned that the patient's family member had had a history, the patient's family member had had a G-tube put in many years ago and lived for several years after having the G-tube put in, and that the family, their country of origin is somewhere where, G-tubes are routinely offered to people with advanced dementia. So knowing that, the geriatrician then shared some relevant information that we don't have any evidence that tube feeding prolongs life in frail patients with dementia, as it seems like that's what the family had been hoping for. Put the peg in, this will prolong dad's life. And then we had a bit of a debrief among the team members after a family meeting, and the consensus of the team was that the interdisciplinary approach was key in supporting the family in goals of care conversations. Throughout the whole admission, it felt like we kept learning new pieces of information the more we spoke with family. Everyone contributed by gathering pieces of the puzzle over time and was able to work out a management plan, that the family expressed that, they felt was appropriate given their values and their goals for their loved ones. Okay, I'll pass it back to you, Dara.
Yeah, I just wanted to invite anyone in the audience to share an example of a time when goals of care information came forward to you, or where you shared something as nurse, allied health, or perhaps a care aide that actually had an impact on the team's approach to caring for a patient or a client. So feel free to type in the chat box. You can use the raise your hand function. We'd love to hear from you.
See.
Lori, did you want to share something? Do you see anything in the chat box, Laura?
No, I think, yeah, Lori, feel free to unmute and just share verbally or enter into the chat is fine. Yeah, no worries. But yeah, not seeing anything else. Any other examples that have come up, feel free to raise your hand. Okay,
Amanda, many times, like you said, it comes up naturally so much in the middle of night toileting, bedside care, often one-on-one and quiet moments, and permission from the patient to share with the team has always been granted. It's a great example. Monica?
Helps if I'm unmuted, doesn't it? Sorry about that. Just an example of supporting a long-term care site. While I work with the Goals of Care team, my background actually is social work, and I was supporting a wife who was wanting her spouse to continually return to the hospital setting. And really what it came down to when we dug into a little bit deeper about what she was hoping for was just the confirmation for herself that she had done everything possible for her husband. And so it wasn't necessarily that she felt there were particular medical interventions. It was more of an emotional rationale for her. And once she was able to have that support from her MRP for her husband, that they could provide that same care in his home setting, it helped alleviate some of the emotional distress that she was going through. And I think that also allowed the nursing team to be able to appreciate perhaps how shifting the way they discussed the options for her husband um, were going to be better received, honestly. So that was, again, just kind of taking a pause, digging in a little bit deeper into the questions and asking some follow-up questions to the spouse, helped all of the team members.
Thank you, Monica. That's a really rich example. I'm just going to move on, and then towards the end, we can revisit some of the sharings in the chat box. So switching to an adjacent and related topic of how we've engaged residents and acute care physicians at VCH, kind of specifically at VGH, because other things are happening at other places. We've offered various formats. So we've had the longer workshops, which have involved the conversation guide and simulation. Shorter sessions are often better received when they're more discussion-based rather than didactic. They're truly learning from each other and sharing strategies with one another, which I think is really powerful. I've listed some of their favorite topics there. I have the absolute honor of sitting with ICU residents about every 4 or 5 weeks here at Vancouver General, and I just let them tell me what they want to learn more about when it comes to goals of care, and these are some of the most common examples that come up. I think it again goes back to how the culture is perceived that goals of care is synonymous with things like code status or a most level. And so chipping away at that and differentiating the two through discussion and dialogue is really, really helpful. Another thing I have residents reflect on is thinking about the patients that they've just heard about in their handover. How much do they know with regards to these sort of 5 questions? When was the last time we found out what the patient or substitute decision maker's understanding was of the health situation in their own words, which is different than when was the last time we provided a medical update? Do we have the answer to what they're hoping for or what their goals are? Their worries, how have they defined quality of life as the patient or the substitute decision maker on behalf of the patient? And what falls into the unacceptable outcome realm versus what is an acceptable outcome from this medical care? And one of the ways that I met Gary was through attending physician training that we provided a number of years ago, and that we still provide sort of on an ad hoc basis. And there's lots of different ways that we've adapted it, but it certainly has helped to have things like SSC funding in the past, to have ongoing CME and CPD credits, to develop champions like Gary to continue sharing that interprofessional approach, and to role model and mentor others in medicine to have the highest possible quality conversations. Being flexible with when we deliver the education and tailoring the case studies for the simulations to the specific specialty, which is something we've also done in collaboration with Providence Healthcare. And then our goals of care support team also provides real-time support, whether that's preparing or debriefing or being present during those conversations to support medical staff in gaining increased comfort with these. And I'm going to pass it over to Gary.
Thanks, Dara, and good afternoon to everyone. And I just want to thank the organizers for including me in this presentation. And secondly, really to appreciate Dara and Emily and the entire team for their incredibly valuable contribution at the bedside with patients and families, in addition to sharing their knowledge with all the health professionals interested in improving their goals of care communication skills, such as me. My journey started actually as a medical student in the last century, can you believe it? When we were introduced to patients in the first week of medical school. It wasn't really to discuss anything medical at all, not the condition, not prognosis or medication, but really to find out who they are. What did they do for work? What did they like? What did they do for fun? What their families liked? If they'd gone on vacations. In other words, it was really to try to find out about who they were. We also had a number of program patients, and these were videotaped. And if you ever want to be humbled, just watch yourself, observe yourself after one of these videotapes when you realize, my gosh, I didn't think it went that bad. But moving forward through residency and fellowship, I had many opportunities to observe my staff discuss goals of care, which in fact, I'll be honest with you, was quite rare. Unless the patients were in ICU or they had a devastating head injury, and then fashioned my own approach, as there really was no formal training in the area. And I had the good opportunity of working in different countries, particularly in the Middle East and India, and these presented unique challenges, having to adapt to local customs and language. And unfortunately, often these conversations were held through interpreters, which really added another dimension of challenge. And after returning to Canada, I did sign up for one of the RPACE programs and became very impressed and ended up adopting much of my current approach and language based on the serious illness conversation. And then fast forward to COVID, where we had new challenges presented and unfortunately required many more of these conversations, and was very appreciative of having the rapid serious illness conversation guide, which proved extremely valuable. And as you've heard, a lot of what I am going to say is repetition from what you've heard from Dara and Emily, but I'm just going to address a couple of the questions that I have here, the biggest lessons, important lessons, the interprofessional approach to goals of care, and what about information sharing? So Dara, can you give me the next slide, please? So these are my own personal views and lessons that I've learned, and one is start before the crisis happens. In other words, don't wait for the ICU. You want to have conversations before there's an acute illness, and in many instances, if patients are elderly or deteriorating or they have cancer, these probably are even best done in the family physician's office or with the internist, oncologist, etc. Because you want to give patients time to reflect, to involve family, and not be distorted by panic or cognitive impairment. So we want to normalize these as routine, not a signal that death is around the corner. One thing that I came to see is that I had to listen more than talk. We physicians tend to over-explain prognosis, but unfortunately, we under-explore what patients actually value. And, just a simple question like, what does a good day look like for you? Or what are you most afraid of? Those answers tend to reveal a lot more than any quality of life checklist that we've been trained to ask. Prognosis isn't really the same as goals, because often we tend as physicians to lead with survival statistics, and unfortunately patients do not organize their lives around probabilities, but more around meaning, relationships, and function. So we have to learn to lead more with values than let prognosis help frame realistic options. Family dynamics, well, I'm sure anyone who's had a conversation with any patient recognizes family dynamics are really just part of the clinical picture. And you need to be skilled in conversations that acknowledge these dynamics explicitly. And you want to avoid pitting family members either against each other or against the team. So it is important that we recognize and deal with them as this comes up. The often, in the past, we used to ask, what do patients want or families want? And then they'll say, well, do everything. Well, what does do everything mean? It means different things to different people. At least that's in my experience. It's usually an expression of love and fear, not necessarily a specific treatment directive, although it could be. And when you say everything, you might just ask them, help me understand what that looks like to you. And when you hear from the patient, it often just really means, don't give up on me. I don't want a ventilator, but please don't give up on me. So having those conversations and having these open-ended questions is really important. The next point I came to see is that hope and honesty actually coexist. In fact, in my view, patients report less anxiety, more sense of control, and have better end-of-life outcomes than if not. So hope doesn't deny reality, but it requires what's worth hoping for within it. And so the goals are really important to be clear, and they should be patient-based. The goal, again, amongst team members is alignment, but you're not always going to have full agreement. So we should understand that we want to honor what means most to patients and a plan to honor that. As far as uncertainty goes, nobody can predict what's going to happen at any time. So uncertainty is part of the norm, but if you admit it, it also builds trust. I've often come to say, I can't tell you exactly what will happen, but I can inform you of what typically happens. And if there's a change in your condition, I'll update you accordingly. So I think it is really vital that we're honest, because nobody has the crystal ball to predict anything. And again, as was said before, it's vital to document and to revisit things often, because goals change as illness progresses. As far as interprofessional approach, complexity exceeds any single discipline. In other words, we're all in this together: nurses, PTs, SLPs, ward aides, spiritual workers, and even a woman who used to clean the ward where I worked at Lionsgate came to me one day, said she's been in this patient's room for 3 days and the woman is crying terribly. And so she asked her, what's going on? And she said, well, I don't know why I'm here. I think I'm dying, but nobody's told me anything. So unfortunately, this wasn't my patient, but it was a cue to speak to the charge nurse, who then, and the social worker, who then got involved. But it hadn't been mentioned to the nurses or any of the other people who had been going into her room. But when this very delightful cleaning woman came in, she was just opened up and began crying. So it's really important that this input comes from all of us. It's not just one person. We need to be consistent in our messaging, because if different team members give conflicting signals, that just causes confusion and distress. And we all come into this with a bit of moral distress, be it kind of burnout or, we all come from different backgrounds and we've had good days and bad days. And so we all carry some, and we may perceive that treatment is not aligned with the patient goals, which also can result in fractured therapeutic relationships. So we want to recognize these kinds of things early and resolve them before we discuss a plan with the patient. Transitions, as others have mentioned, that's where things kind of can fall apart. Shift changes, handoffs, team changes, unit transfers, and often it is important. Certainly in the ICU, we discuss it every day, but it's probably important everywhere to discuss on the rounds what the goals of care are and make sure that the patient's values are well appreciated. And then just the social and practical barriers are just as real as clinical ones, meaning that, You know, if the goal is to get a patient home, we need our social worker and our care workers to know whether this is even a realistic goal. Next slide, please. So just in summary, we're all part of this team together, and we need to advocate and be professional in our responsibility to speak up. What you know cannot be assumed, so we really have to have a low bar to bring relevant information forward. Documented in the notes, related to the other team members. I can't emphasize that enough, because silence has its consequences. If the patient's wishes change at some point in their care, going from, you know, full investigation and treatment to, well, maybe that's not what they want, the default will always be the more aggressive. So we do need not to be silent. And if nurses or anybody in the allied team raises a problem and feels dismissed, please, please, I encourage you to raise it again, maybe through some other person, but definitely don't stay silent. And lastly, there are gaps between what is the plan on the chart, be it full resuscitation, versus the patient is saying, hey, I've had enough. And that also needs to trigger a review, and it can come from any of the team members. And we really just are protecting something that's irreplaceable, because often families regret not having had these conversations earlier to reflect the patient's wishes. So it's very important that we all speak up. I'll take the next slide, please. Again, there's a lot of studies now recognizing the value of interprofessional collaboration amongst nurses, allied health professionals, and physicians. Not only does it improve patient-centered care, but it also improves outcome. So we are blessed at VCH of having such a fantastic team who readily is available to offer guidance, and it should be utilized. Not just, it's great to be there, but it needs to be utilized. I'll take the next slide, please. This is from a study that talked about a learning pathway grid and went from a very physician-dominated, toxic kind of culture to a much more constructive one. It was dominated by physicians whose comments like, I don't need to explain my rationale, and others would say, well, my opinion is not valued if asked. And they ran this program for about 2 months. And at the end of it, they had an incredible reset, such that there was now shared reasoning. Nursing had equally valuable knowledge. People thanked each other for speaking up, and the teams were much better able to align on the care plan. Next slide, please. In this particular paper, it went from what do you think, or whatever is that person thinking, to what is their frame, both WTF, but it was a real transition. And what they used was curiosity, respect, and transparency. Name the problem, describe what you observed, share your interpretation or your concerns, invite their point of view, and then you kind of negotiate the next steps as to what works for everyone, rather than not be steadfast in your individual positions. Next slide, please. So this, again, in the closing discussions, we're interested in hearing what some experiences you've had with training or supporting medical staff goals of care conversations, the kinds of questions you asked when training residents or medical staff, or using the serious illness conversation guide, and what barriers have you been able to recognize and overcome, and what has helped you overcome them. So feel free to respond in the chat box, or even send an email to one of the organizers, because I think everyone's input here is extremely valuable. And last slide, please, I believe. Together, we are transforming goals of care culture. Goals of care conversations, as we said, are everyone's responsibility, not just the physician. We want to normalize goals of care conversations on admission. We want to revisit it throughout the hospital journey. Everyone's input and perspective is essential because, as I showed you before in that little story, patients choose who they trust. And certainly, often it's not the physician who's only there for a short time, where Emily and her team or the physiotherapists or the nurses are there with patients much, much longer period of time and get a much better understanding. And we need to reset from indignation and kind of physician-based to more of a curiosity and what's their frame. And therefore we can transform teams in a much better and productive way. And really, humility and inquiry or curiosity really is the foundation of interprofessional collaboration. And with that, I want to thank everyone who's come to participate. And hopefully there's still some time for questions, or maybe not. I apologize for that.
Yes, thank you so much. No worries at all. We're at 1:03, but if there's questions, I have time. Welcome to stay on and use the chat, raise your hand to ask questions, because just a great amount of content and things to think about from our presenters. So yeah, feel free to ask away. And I just saw there was a question about getting the link to the recording, and it will be sent to you with a summary of the session in about a week's time. So you don't have to sign up for anything. That will be sent to you automatically. Just saw that. Any questions? Lots to chew on and think about here. Let's see. I see Laura. I think Laura Wong. Go ahead and unmute and ask away.
Hi, I'm just a little curious as to the challenges in terms of coordinating the communication between the care team, because it's great to say before we go in and have these conversations, we meet, we have consultations, but then I respect, people have varying intensive schedules and different people, and the capacity to communicate, I think, may be a barrier in being able to get the team together. So I'm kind of curious about that, as well as whether or not there's it's not a single point access, but a single point coordinator for the team then to help compensate for that. Ideas?
I'm happy to take that one and then have the others chime in. Laura, I think, yeah, much to your point, in acute care, but also in other settings, clinics, etc., workloads are high, and finding time to meet and have that coordinated effort is certainly a challenge. I think it's a challenge we need to aspire to. I think it's a series of the small conversations that happen in the hallways to exchange vital information. However, if there is a scheduled family meeting coming up, it doesn't need to take 10, 15, 20 minutes to gather and have a coordinated approach. I think all of those small conversations begin to inform the big picture of what you're anticipating might come out in a family meeting. And so taking even just 5 minutes before the family meeting to gather as a team and articulate the absolute most main things that you want to convey. But mainly, I hope what we've conveyed today is the importance more of asking curious questions. And so who's going to lead the conversation and ask some of those curious questions? And then at what point will that lead seek the input from the various members in the team? So, at what point will that lead cue Emily to share, what she's heard from her time with the patient when talking to the son? And I think that time is well worth it, because the time we front load and spend up front will ultimately save us time in the long run. The more coordinated the approach and the better quality and cohesiveness to that family meeting, the more likely you are to be effective as a team and to reduce the likelihood that yet another family meeting needs to happen. Chris?
Yeah, thanks for the presentation. It was more just a comment. I realized probably this audience is already I'm preaching to the converted, but I totally agree that it should be like it's no one's response, like it's everyone. We all should have those small, these progressive conversations discussing this. It's been interesting from my experience where if the physician is involved and reinforces, say, like the mobility and it's more of a cognitive impairment, progressive decline, that's so helpful. But conversely, if the physician is not, like they're just totally avoiding it, it made it hard. It can make it harder for the family because there's still a bit of that. If the white lab coat person is not saying it, then it can't be. So it's so much more helpful to have the medical, especially the physician side, be on board because it makes this whole conversation a lot easier to kind of plan ahead where we're trying to be more proactive, especially, okay, this is where we're at, setting the stage for the future. So it doesn't all, blow up in acute or ICU, like this is coming. And so I found it very helpful when physicians are part of that. And then also when they're not, it's so much harder. We still try and have them, but it's harder to get buy-in compared to that. So just more a comment.
Thank you.
Thanks, Chris.
I was just back to sort of the question I asked earlier. So one of the reasons I asked it is because I know there was a study or there was a project done in Australia where they had someone who went in and had more like advanced care planning discussions with patients in the hospital. And I want to say that was about a decade ago, maybe, but it was considered highly productive in terms of like the overall sort of health economic benefits in having a person that is dedicated in the formal system to that role. And that's kind of what I was asking. Like, would it not make sense to have a unified person, not thinking of just in acute, but in general within the healthcare field, I guess, as opposed to just a coordination. I mean, it would include a person who then can amalgamate those bits and pieces of conversations that happen little by little. But I'm just curious if anything like that has ever been discussed or thought of.
I think there's lots of different interventions that have been trialed out there to maximize that team-based approach, some of which have involved interprofessional education workshops. Others have involved having that sort of liaison person involved that at least initiates the conversations. And I always also circle back to that definitely is of benefit in a lot of situations. However, everybody at the point of care needs to be equipped with those conversation tools in their toolbox for those natural organic moments that do arise. And we still need a workflow that makes sense to ensure that gets shared from that informal point of care interaction to the rest of the care team. Because they happen when you least expect it. When you're inserting a Foley catheter, or as Amanda said, you're toileting someone at 2 a.m. And so having a point person is a concept that's been tested, and definitely there's benefits. And I think on top of that, we continue with the ongoing upskilling of all staff across all professions to stick handle these to the best of their ability.
If I can just add a little bit, I do agree that it sounds like it's more difficult, but the fact that we all document in the same place and we can express our concerns about each patient, ultimately we are responsible, either as physicians or nurses or any member of the healthcare team, to read what other people say, and that might, be an avenue to express what the concerns are. Granted, it's not always going to be ideal, but I know that when I go in to have discussions, often, I want to have other people's opinions before, having the family discussion, or even often our discussions happen in the emergency department where it's, should they be going to ICU, etc. And so you want to grab a family member, or you grab the nurse who admitted the patient, you take a moment to look through the chart to try to get some background. So that background is what I look for. What did the last admission, when were they discharged? What did the OT say? And then I can incorporate it into my goals of care. Like, what are the things you think you couldn't live without? What would it be like if you couldn't get up and take care of yourself or shower? So I think what we're saying is all the same. We want to have a valuable contribution, but by all means, if you recognize something, either speak to someone or document it, because that's the place that we will go and look for before we go talking to patients about goals of care.
Great. Okay, well, we are at 1:13, so thinking we should wrap it up. But feel free to put any other questions into the survey or it comes up, or I'll just pop my email into the chat here, and you're welcome to message me or email me any questions, and I'll be happy to send them along to any of our presenters today as they're relevant. But just wanted to thank you everyone for joining in your busy schedules and lives and engaging and listening to this important learnings. And thank you so much to our presenters, Dara, Emily, and Gary for being here and sharing your learnings. As we said, we'll get the recordings and summary in about a week's time. And yeah, in the meantime, thanks so much for continuing on the good work of essential conversations and having more, better, and earlier goals of care conversations. So anything you wanted to end with, Dara? Okay, great. Thank you all, and hopefully we'll see you at our next sessions as they continue on into the summer. So thank you.
Bye.
Thank you.
Thanks.
Thank you.